well as public health, and is a clinical epidemiologist, intervention and implementation science researcher at Yale University School of Medicine and School of Public Health. Dr. Altice's primary research focuses on interventions and implementation science at the interface between infectious diseases and addiction, and he has conducted research in several global health settings. So please join me in welcoming Prosper Altice.
Willie, thank you so much for that really wonderful introduction. And what's really nice about the way that things have evolved, and I just have to say that one of the things that's been a lot of fun for me is how much I've learned from my colleagues. And the lecture right now is going to really move from some of the principles and the theories and the biostatistics to some of the real-world implementation. And following me is Jen Edelman, who is going to be doing some of the same, where we're going to be able to sort of demonstrate some of the things that we've learned and put it into sort of what I call applied implementation science. And so anyway, this has been a real sort of lesson of love and a lesson of pain to sort of go through whenever you do disruptions in terms of your implementation research. And so let me just acknowledge my disclosures here with regard to consulting and research grants. And what I'm hoping to do in terms of a real-world practical implementation is to use an implementation science to review some of the methods. And we're going to actually, this is going to build upon Lynn's presentation on Niatex. I will say that Lynn introduced me to Niatex many years ago when we wrote this grant. The story starts beforehand, but you know, they were really struggling, and we said, how do we do this? And so I went to Lynn back in 2012, maybe, when we wrote this grant. We did the original work to sort of understand it in 2010. And so I'm mostly going to be presenting from the grant, but there's always all of the contextual things that happened before that. And to really describe how the Niatex model was adapted, so Lynn talked about all of the research that was findings from the US, and we found that Niatex needed to work a little bit differently. So we added a couple of other tool pieces to that and talk about how that sort of works out. And then I'm going to really center that around the disruptions that occurred in Ukraine. There's probably a third disruption. We've got the data for it. We haven't analyzed it, but really about the scale up that occurred, you know, as it relates to the COVID-19 pandemic. And then more recently with regard to the war, and of course, very sadly, the war continues on there with the work. One of the things that we know about implementation science is it takes a village. We have a ton of people from the Yale team, from every discipline imaginable. We've got an incredibly adept Ukrainian team from two different organizations. One of them is a service delivery NGO, and the other is a research NGO. And then I'm not going to really present a lot of the work on the modeling, but we've got a team from the UK that's been doing a lot of the modeling to take a look at what these interventions are sort of doing. This is one group from one NGO in Ukraine that has been working. I've been working with the guy in the upper left-hand corner. I usually don't have problems with my left and my right, but anyway. Sergey, who I met in 2004 when we first started this work, and he has been sort of my Adiba from Malaysia for many years. I met them both around the same time. These are some colleagues from another NGO that is actually in the service delivery, and they're sort of operational around the delivery of OAT for HIV prevention. Sheila and Julia Rozanova, Sheila you'll meet today, has been sort of branching out, so whenever you create some synergies, you can start to work in new areas, and they're working in aging and HIV, which has been really a very sort of productive. And so one of the things I want people to think about as you hear some of this story is that things can build upon. I know Sten is here going to be working with cervical cancer screening, so these things can actually build sort of synergies and relationships over time. And then there's a bucket load of folks from the Yale team. Lynn and Scott have probably made 30 trips, at least, to Ukraine. So we have really learned a lot about the context and our colleagues. And then, of course, like I said before, it takes an army. So let me just sort of skip over. I thought I got rid of these slides, but I didn't. What we did is when we first started this work, gosh, now over 10 years ago, when we first started getting started, we had fewer frameworks. We didn't have the 100 plus that we have now. And we used the I-Pairs framework, which really sort of looks at unique factors that are associated with the context, and we'll go over some of those. Some of the innovations, or the lack of innovation, we were using medications for opioid use disorder, specifically buprenorphine initially and methadone. And you can imagine that how does an innovation work whenever the people in the country were demanding that methadone be introduced in a place for HIV prevention, infectious disease doctors, but it was the patients or it was the physicians who were providing addiction treatment who didn't believe that this worked for addiction. So it was the intervention, the lack of innovation, was foisted on the implementers who didn't believe it worked for their field, but they were having to do it for HIV prevention. So imagine sort of layering on this evidence-based practice. The facilitation, I get to cut through a few slides. The NIATEX is what was used for that sort of process. And then, of course, how did it lay on recipients who were sort of subjected to the same influence from Russia, where even methadone and buprenorphine are still banned today. So let me just sort of walk through some of the places that it might be of some benefit, just to make sure that you have that method. I mean, both countries introduced medications for opioid use disorder, both Malaysia and Ukraine, at the exact same time. I mean, this is almost a superimposed sort of place. We actually looked at the evidence-based toolkit for HIV prevention. This is in a place where the epidemic was primarily concentrated among people who injected drugs, and they were doing so mostly with opioids. And we looked among our toolkit, and we looked at our coverage of opioid agonist therapy to readily try to get them up to at least 20% coverage. There are parts of Western Europe that are at 40 to 50 to 60% coverage. WHO recommends, in order to sort of shut down the epidemic, you need 40% or more coverage. Places like the US are at 11%. Places like Ukraine, when we finally introduced NIATEX, was at 2.7%. So this is what we were sort of looking at. And I'm not going to spend a lot of time, but essentially opioid agonist therapies are very effective. The clinicians and the patients really saw this as the treatment of last resort. There was not enthusiasm to recruit patients by the clinicians. There was not enthusiasm for the patients to enter into treatment. So when we think about Rogers' diffusion of innovation, it was really only those innovators when we first got started. We introduced buprenorphine in 2004, 2007. We introduced methadone because buprenorphine was too expensive, and we sort of hit a plateau. We got some more money from the Global Fund, and then of course I'll show you how some of this works. But the bottom line is it's very effective, but if the people who are being asked to implement it don't see it as effective, you can imagine some of the strains that went on. And one of the reasons I bring that up is the term that they use for them are narcologists. And of course, if you ever use your typewriter and type this in, it always changes the word to necrologist, which is probably not such a good thing to have happen. But that's how they saw this medication. The narcologists were becoming the necrologists of the country because they really saw this as a last resort, the sort of thing that would actually kill their patients. And so one of the sort of lessons that I'll go into that we learned is that these were the folks who really needed to be our change leaders. And we first started out with a group of folks who were mostly from NGOs and stuff like that, and they did not have the executive sponsorship in order to make a difference. And so we made a change. So this is once again, one of the things that you sort of make in terms of deciding who's going to be your sort of work. The other thing that we sort of really looked at what was going on, this is a modeling study from 2010, 2011, and it really looked at what are the most effective, and they sort of stratified two different evidence-based interventions. There's methadone with what they called high, medium, and low coverage, and they looked at antiretroviral therapy treatment as prevention, as with low, medium, and high coverage, and then they combined them with limited treatment or with sort of expanded high methadone, high ART sort of coverage among people who injected drugs. And what you can see is that you get the most sort of benefit when you combine them both, which is great. So you're sort of working across two different types of prevention. But if you're looking at a single intervention, you get the most reduction in new infections in a concentrated epidemic among people who inject drugs by just scaling up methadone. So it was there. And when you apply the cost metrics to this, methadone being pennies a day, antiretroviral therapy being several $1,000s per year, the cost effectiveness was that to prevent one infection, it was going to cost about $530 versus $2,200 for just scaling up ART. And of course, there's an intermediate effect when you scale up them both in terms of preventing new infections. But if you're in a low and middle income country and you have a limited amount of resources, you might make choices around what sort of things are going to give you the most HIV preventive effect. And of course, the right thing to do is to do both. But on the bottom line is that if you have a limited amount of resources, you would sort of use the things that you can get the most benefit from for the least amount of cost. Let's talk about the setting a little bit in terms of what's there. So my story there began when I was invited to an addiction treatment conference in 2004, and it coincided with the Orange Revolution. And so one of the things that inspired me about this particular place is that these were people who were standing up to the old guard around Russia. They were making a difference, and they were making a stand. And what they were doing was they were revolting against the candidate who was put in place by Russia, but he was not duly elected, all right? So this is what's going on. So it was an inspiration of the people that was sort of the initial sort of driver. And Lynn and Scott and I can tell you that this hotel that you see in the bottom right-hand corner, that's the Hotel Ukraina. It's an old Soviet hotel. We've stayed in there many times, but I was staying in that hotel, and these were the views from my room in 2004. It was not long after that, while I was there, we were talking about how to pilot buprenorphine and get started in 2004, 2005. We initially scaled it up. We got 700 patients on treatment. It was basically, we brought the clinicians to the US to get some training outside of their setting. So the context didn't matter. We needed to take them out. And it was really interesting. I think people were asking me to take off my hat so that they could see my horns, and to sort of remove my sports jacket so that they could see my tail, because they had decided that I was the devil incarnate. And we brought them over, and we actually let them see patients get treated. And they would come in looking somewhat disheveled. 2 or 3 days later, they would come in showered, they would come in dressed, and they actually got to see the immediate response of treatment. And so we had our sort of early innovators right from the very beginning who were beginning to make a difference. But because of resources and because of buprenorphine restrictions and a number of other regulatory things, methadone was sort of the next thing. So that by 2010, 2011, it was actually the rate of increase was beginning to stall. And so the folks over there who were implementing these programs sort of reached out and said, can you sort of help us understand? I said, well, I don't know what's going on. So I said, let's take a look here. What they were dealing with is they were dealing with a population of people with HIV of 360,000, the highest HIV prevalence at the time, actually even now in all of Europe, 1.2%. The actual number of people with HIV in Eastern Europe and Central Asia is highest in Russia, but the actual prevalence is highest in Ukraine. They had a similar number of people who injected drugs, and then the people who were using opioids was about 80% of them. There was about 280,000 or so people. So they had a lot of people in terms of thinking about coverage. And by the time that we were starting to do some of this work, at least initially, doing that assessment, the coverage rate was about 2.7, 2.8%. So they were well below. And what was interesting, it wasn't a resource issue. They had enough PEPFAR money to get 30,000 people onto treatment by 2015. So it was not a resource allocation issue. There were all of these other sorts of things that were going on. What we did know is with this volatile epidemic, it was concentrated in people who injected drugs. They were we already had done a number of assessments and surveys, negative attitudes about opioid agonist therapy by the clinicians, negative attitudes by the patients themselves, and an incredibly rigid setting. This is one of the problems with protocols and guidelines. So they develop these SOPs. They are rigid. People need to see them as guidelines, but people saw them as the gospel in terms of what you do. You must do this, you must do that. But the question is you always have to do things in order. So in other words, what they had required is that in order to get a diagnosis, unlike the rest of the world, you had to go into a hospital and they got to watch you withdraw from your opioids for 3 days and say, aha, the person is opioid dependent. Maybe we can make a diagnosis of opioid use disorder. So patients had to be traumatized and suffer in order to get a diagnosis. Once they got a diagnosis, they had to get 3 narcologists to all document and sign off that it's really a person who's not going to get this medication. They had a procurement system that was so bizarre and so complex, with people on different cycles and different times and with different routes around the country to move methadone around, that there was no flexibility, so that if one place did well and they sort of used up their medication, there was no other room to move, while the rest of the country had no medication whatsoever. About 2012, they developed something that was called Order 200, which was their regulation around treatment, which said that a person had to fail addiction treatment twice before they could actually get a medication. Could you imagine going through withdrawal, getting diagnosed, and fail this detox program, which is deadly, by the way. Detox is deadly. You detox somebody from opioids when they have a chronic opioid use disorder, their risk of death goes up dramatically because their tolerance goes down, so they were putting people at risk. And they had a requirement at that time that every single person must come into a clinic 7 days per week. The only thing that any of us do 7 days per week is eat. All right, there's nothing else that happens with that, and that's only whenever it's convenient we have food that's available to us. So what we did was we sort of first had to set out, and we had to really sort of understand what were the barriers, and they were actually incredibly complex. We created this socio-ecological model that would scare you all to death with all of the issues that were going on with regard to the system. And right as we were getting started, we were beginning to think about this, Russia invaded Ukraine, the Donbas region, and Crimea right about this time. These are my photographs from being present on the ground in the Maidan, which is right underneath of this hotel when all of this was going on. It was called Black Friday. Those are Molotov cocktails. This is real warfare that is going on in the street. I was on the plane when this happened, and they moved my hotel to a different area. So this was all unraveling as we were trying to explore some of this. And so that is the context in which Lynn and Scott got to come over to Ukraine and to begin to make change. But what was interesting is this is number 2. We have the Orange Revolution of 2000, it was a revelation too, but it was the Orange Revolution of 2004. 2014, we have the first invasion. Fast forward to 2012 when we have the current war. Lynn had done this, Lynn and Scott had done this incredible work with Niatex. They came on as, to really be involved in this grant. And let me just say that this whole process improvement, if you sort of take a look at the sequence of what happens, all of the learning that happened from the original investment, so this is how we talk about sustainability, added on layers of learning that was sustainable when COVID came along and when the war came along, all right? And I'm going to show you the data for this because the data are the data. And as Lynn likes to say, the data are our friend. So we have to really think about that. I'm going to skip through this very quickly. This is my quick look at Niatex. Lynn is the president of Niatex, so she gets the real card-carrying membership thing. But I have this sort of thing. You come up with an aim. Our aim was to increase the number of patients on opioid agonist therapy. We had a series of change projects that you all heard about. The 3 rules were that you use the existing resources. There was no extra money that was coming in. You have to be able to measure the change. Fortunately, we had a national database that we could do that. And then, of course, to keep the gains as you get them. The people, we had an executive sponsor. We didn't make the right decision at first, and I'll show you the data, how the curve didn't really shift when we used a different group of folks. So we ended up going with the chief narcologist, or hopefully, and they've actually turned into narcologists, not necrologists, actually, after overtime. And then we had the right change teams to make a difference. And then some of the tools that Lynn went through were all there. But what was interesting is we didn't always have the nudges that we wanted. We sort of recognized that we had to do some things differently because all of the work had been done in a high-income, context. These are clinicians that were making about $200 per month. There was no money. There's no continuing medical education that comes within the country. All the continuing medical education is coming from Russia, which just says, don't use this. So we actually had to create some stimulus lectures and some learning around treatment. And so those are a couple of the things that were sort of innovations. And to take them outside of their context to the US. each of the regions in the country, there's 26 different regions, and there's a chief doctor, a chief narcologist who oversees all of the addiction treatment, and we made these our executive sponsors. This is a group, and I have to tell you, what's really been interesting is that until we brought these people together with the collaborative learning, with sort of changes, sort of presenting their ideas, new promising practices, they developed ideas there that didn't happen anywhere else. And they used those things in order to grow. But what was most important, and that we didn't measure until later, is the collaboration between these folks. All of a sudden, people had each other's phone numbers. They called up, they spoke to each other, they said, oh, we're doing this, and somebody, they might secretly say, well, how did you do this without getting into trouble? They really learned from each other, and they learned from each other not only informally through their own networks that evolved over time, but formally when we would bring them together at least 2 to 3 times per year to present the changes that they've done, their gains, and we could actually have them present their information. We also would give them stimulus lectures where we would turn back their own data. This is what you're doing, and etc., to reinforce those sort of learning. So let's just walk through this curve just a little bit. You're going to see this sort of repeated as I go through. So we have 2014, we're there, we're assessing the barriers, we're trying to understand what gets in the way, nominal group technique, we've published the papers, I mean, it's all out there. This study alone, I think, has published like 40 papers. So it's been, and it's been one of those grants that's been repeated. We've been funded successfully for over 12 years now. And one of the things that we did was when we sort of really understood what all the barriers were, we got all the sort of the involvement. What ended up happening was the Ministry of Health decided, well, we're going to bring these doctors together and figure out how can we do things differently. Well, they had really contributed all the data. They were the drivers for the change in Order 200. And Order 200, remember, is the regulatory structure by which methadone every day, 2 detoxes, all of these other sorts of things. And what we did there after that is we had already started the Niatex, and we weren't really making much sort of headway. You can see that curve is relatively flat. And then what ended up happening was using these barriers and these sort of executive sponsors coming together in a collaborative environment, they really pushed the government to change the rules. There were a couple of change projects. They did a buprenorphine prescription. They did a number of different things that would begin to sort of create the sort of foundation for being able to make some changes. And so that Order 200 actually changed, and we also recognized that unless we involved, remember Lynn talked about the customer, the patient, the other customer is the chief narcologist, right? And until we had really involved them as part of this process, we didn't get these changes. And so we changed the way that we did Niatex in terms of ordering things. And then some of the things that we did as part of this process is we would set expectations. We call these challenges. These were behavioral economic challenges that happened. And the Change Project said, all right, what will it take in order for you to increase the number of patients by 20% in your region? So that is the expectation. So we set that expectation out immediately. They were continuously supported to get that way through regular coaching calls by the Niatex team. So we had coaches that worked in the country, first initially collectively across the board with equal coaching, and then we developed mini collaboratives with that to focus on places that already had high coverage or low coverage, or really where there were a bunch of innovators and stuff like that. And then they got rewarded with very small amounts of money, but it was big money there, In other words, if the chief narcologist ended up sort of scaling up by 20%, they would get $2,000, over the course of a year. If you think about the cost of HIV prevention, $530 per HIV infection, they were scaling up by 20%, so there was a lot more infections that were averted based upon these challenges, and I call them Challenge 1 and Challenge 2. And then one of the things that we did was we also created some learning visits, so they would actually be able to see how things are done outside of their country. They didn't know what else was done. What they knew was whatever their colleagues had done. So they got to come over to the US, they got to see how it was done in prisons and jails, they got to go to the App Foundation, they got to be able to see other places that provided treatment in very different ways. And of course, I remember their eyes, growing like saucers. Oh, you let them take this much, liquid out of the thing. That seems like it's too concentrated. They're going to overdose. And there were all of these sort of myths and notions that were and I have to say, they would oftentimes look at us and make comments privately, because I was asking some of my colleagues who spoke Russian and Ukrainian, what are they really saying? You know, it was like, oh, you're crazy, you're crazy. Well, the next thing we know, 2 months later, they're doing it, right? So those lessons were learned in a way that, you know, there was some disbelief. But then, of course, with the sort of the learning visits, the other thing we did was we did these other sort of lectures that we call stimulus lectures, where they learned about what is the real evidence about treatment. Why it works for HIV prevention, why it's important to scale it up, what might be the long-term benefits, how it might bring families together. Lynn introduced the Basis 24, and they said, well, our patients aren't getting better. Let's measure that. And you measure that, and you can actually see. So these were a lot of the things that we added to the Niatex toolkit in order to adapt it to this particular context. They're poor, behavioral economics, learning that they did not have from a CME type of program. And then, of course, I'll eventually get to the second invasion and what happened with that as well. So our basic principles were simple. In order to increase the census, all right, there's 2 ways to do it. And Lynn talked about those 4 things of Niatex. You got to bring more patients into treatment, and you got to keep them from dropping out. It's really as simple as that. So, you know, I love to say keep it simple, but it's also got to be something that you could measure. We had a national database of every person who gets prescribed. If you go to the U.S., we have these prescription drug monitoring programs, at least for buprenorphine and not methadone. We have ways to measure whether this is happening. And so when people would say it's going up or it's going down, we could just say, we know what it's going up. It's going up by 300 per month or whatever that number is. And one of the things that's really clear is that as you increase census, that is, as you get better with volume and doing the work that you need to do, you just are better at it, and it results in better quality. You get more patients on treatment, and so they had stimulus lectures that went on how do you get patients onto proper dosing. We started out, the average dose was 60 milligrams. It ain't 60 milligrams anymore. We got them on evidence-based dosing, and we showed them their own data in order to do that. So let's go back and take a look at how we began to think about this, because really when you change a policy, that is a disruption. It's a disruption in terms of the way that you do care. So Order 200 being changed. What happened during COVID was the Ministry of Health says, we want to reduce community mitigation. We do not want patients unnecessarily to have to go into the clinic every day. So we're going to allow you to give take-home doses whether or not they've actually earned those benefits at that point. We want you to use provider discretion in order to do this. So what we have is we use one of those less robust methods, but it was the right method for a change in policy in order to understand. We looked at what was the curve, essentially, that happened before Order 200 was changed. They could all of a sudden get take-home dosing. They didn't have to have the 2 detoxes. There was a lot of flexibility. They could have prescriptions. They could do home deliveries. They could do a whole lot of things differently. And we said, all right, what happens at this inflection point? And unlike what Denise said about COVID, where things may happen at different places around the country, the entire country did the same sort of thing, but it may be the case that some of the places were later adopters than others. But you can sort of take a look at it, and using ITS, you can actually see the difference in the slopes. And guess what? That's a big difference. I'll show you the data in terms of statistically what that looked like, and sort of breaking that down a little bit. But you can see that just changing that with a disruption of the order, a structural change, you actually see this sort of increase that happens that is very real and very time dependent. And then, of course, we're going to break down a little bit what happened with COVID when they got to sort of move the take-home dosing even earlier, and to see whether that actually makes a change. And you can see that that curve changes. And even though we haven't applied the formal statistics to it, I think just from eyeing the data, you're going to see that the same thing happened after the war, after an initial sort of drop. So let's take a look at what happened. What were these challenges? This is not part of the traditional Niatex toolkit. We set the expectations for number 1 to increase the proportion of patients in their region of the country or their state. It would be like Selangor or Kelantan or any of these other sorts of things. And we said, what does it take to increase by 20%? We had 7 regions that increased by just over 20%. We had 1 region that increased by really 72%. These were the champions. Remember, not everybody does it the same way. They have their own ways of doing it. And then we had what was in Rogers' diffusion of innovation is the laggards, the ones who did absolutely nothing in order to sort of change it. And this is what you would expect, right? That you're going to have a differential response depending upon the leadership and the types of change projects that they do. So you can see that there was some huge variation. A lot of people talk about Ukraine as being sort of the East and the West, the East being closer to Russia and the West being closer to Europe. We didn't really see that. I mean, we actually saw a lot of the places that border Russia that were actually very progressive with regard to their changes, and so there's some differences. So one of the things that we did in terms of our interrupted time series is we looked at the first disruptor, which was in Order 200, which is in November of 2016. We had actually identified the promising practices. We got rid of a lot of things that could happen. And the other sort of thing that happened with that, it sort of turned into another R01 in terms of a cluster randomized trial, is all of a sudden methadone can be given in primary care settings. So we did a 45-site study. I'm not going to present the data. It looks fabulous. It works. So decentralizing the services actually worked. COVID-19, they all of a sudden were allowed to take home more doses, and then of course, they actually got to take down at home longer take-home doses during the Russian invasion most recently. So what we decided to do, and I have to tell you that from the NIH's perspective, they had thought that Niatex was just done. It was studied, it was finished. What more do we need to know? But it had never been done in a low or middle income setting. And so there may be some differences. And I have to say that, being able to say, okay, it's not working the way that it was known to work before, Lynn was able to say, we've got to do something different. So we did our own disruptions in terms of making some of these challenges and some of these stimulus lectures. This vertical system required us to change who was the executive sponsor. We ended up introducing a lot of ideas, so nudging with new ideas that they could actually either choose to adopt or not, and we saw some variation in terms of the way that happened. We had learning visits outside of the country with what we call Trip 1 and Trip 2. And then we really recognized that unlike some of the Niatex stuff that happened, no one had really thought about the idea of collaboration as a measurement or cohesion. Were they working as a cohesive group? So we found a measurement, not typically used in implementation science, called the COPAN-3, which really looked at that. And we looked at the implementation leadership scale in terms of their risk-taking. And we found a group of people who would adopt new things and to really put those measurements to see if we could sort of uncover some differences in the way that scale-up might look. So we collected all of these various different data. Did they go on the trips? Did they scale up? Were they risk takers? Were they really on the collaboration climate scale? That is, they worked with other people really well. We took all of those measurements and we came up with terms. And so, whether you use principal components analysis or latent class analysis, we came up with groups of individuals who sort of hung together, if you will, to see if we could see if they did things differently. And so the first group that came up is these delayed adopters. We tried to use nicer language when we first wrote this up, when we first started talking about these folks, we called them the laggards, but I didn't think they'd like to be called that later on, so we called them delayed adopters. And they were pretty, sort of low on the leadership participation. Did they come to our meetings regularly? They were sort of, half of them scored, high on the collaboration scale. 100% of them were low on the risk-taking. They wouldn't adopt new ideas, so they're not taking new ideas. And essentially, they just didn't go on any of the trips and stuff like that because they just weren't doing anything. They weren't people that we thought would actually be major influences, etc. And so that is that group. And so we can take a look at it. The second group were these independent operators. And sort of in American nomenclature, I call them the cowboys or the cowgirls. They were the ones who, they wanted everything new. Let's right off to the sunset, and then they were gone, and the cows were, streaming in the countryside later on because you left them to move on to the next herd of cows. And so, but they were risk takers. I mean, they had some really good ideas, and they did a number of different things, and so they were a little bit different. And then these engaged collaborators really scored well on collaboration climate. They were, fairly good on, going to trips and coming to the program. And they were a little bit risk takers. 63% of them scored, high on the risk taker scale. So they're a slightly different group. And so we come up to these three groups. And then what we did is, remember in that interrupted time series, we took a look at what happened in terms of the two factors that were important for scale up. That is, are they taking new patients or are they dropping out? And we just looked at what was the net gain in the number of patients, irrespective of either one of those sorts of activities. And what you can see is that whenever we looked at this, the engaged collaborators were the ones who had the highest rate of increase in their census over time. What's interesting is that the risk takers, they didn't really get anything special. Their collaboration wasn't necessarily as high. And I would say that in a real world setting, they probably represent people like some of you all who would be the people who would try something new, but without learning from each other. You'll take new ideas. And so these are people who happen, I think, naturally in sort of healthcare delivery. And then, of course, the laggards, we all recognize, no, this is the protocol, we can't do it this way, this is too risky, I can't make this change, or it's too much work to make that change. We all recognize all those sorts of people, but what you can see is in terms of new patients they were bringing in, the engaged collaborators were the most robust. Now, this is taking in new patients in the census, but let's take a look at what happened with dropout. Well, what's happened is that the lowest dropout is on these engaged collaborators. They had put in new ideas, but they sustained them, right? They kept them, they kept moving them on. Now, the other people who were doing nothing different, their numbers looked okay, so they were in the middle. But our risk takers would take on the new thing and then abandon it and go on to the next, sort of grassy pasture, and they had the highest amount of dropout. So they sort of came back down to the mean in terms of doing that. So they would bring them in, but they would lose them out, all right? So we recognize that as well. So we really have something here that was sort of driving these factors, these stimulus lectures by going to the, to the meetings regularly. That's where they got that access to information. These are the factors that sort of worked, at least in this LMIC, low and middle income country setting, where there was a difference. Now, one of the other things that we learned with this is that we were trying to do this with HIV prevention. And remember that earlier modeling study where it was the combined, sort of scale up of methadone, but then were there any sort of secondary HIV benefits? Well, what we did was through a large sample of people that we recruited, we were able to really create the HIV treatment cascade. And we recruited, and we repeated it again in 2022. The data look even better. But essentially what you see is that, the people who were sort of meeting the 95, 95, 95 levels, is that we found something that was really interesting in the most recent data. It was over 2,000 patients, over 500 of them had HIV. And we were able to stratify them by 3 different categories. The first category was they're on methadone, all right? They're taking a medication. Systematic reviews and meta-analyses suggest that methadone is very effective at improving the HIV treatment cascades. We know that. But what was interesting about this, on the far hand right in the orange, these are the people who were not or never on methadone. What we did in this new analysis is we looked at the people who touched the system. That is, they touched the methadone program, but they weren't perhaps still on it. And what it seemed to do is it gave them a jump start in the HIV treatment cascade so that they had time to learn how to take their medications and do really relatively well. So in terms of diagnosis, it's structural. You go into treatment. We had taught everybody to bundle HIV testing. Everybody was getting tested, essentially, so they were doing really well. The linkage to care looked pretty darn good, significantly better than the group who was never on methadone. So true for the prescribed antiretroviral therapy and the adherence. So what ends up happening is you have that initial droppage in linkage to care for the people who drop out of care, but the rest of the cascade stays pretty consistent thereafter. So just touching the system and getting diagnosed and jump-starting that process is probably a really important, and it has sustained benefits down the road in terms of HIV transmission with regard to HIV treatment as prevention. So let's take a look at what happened. So we had 3 or 4 years where people had made all of these changes. They had learned to work together, they were collaborating, and they were continuing to make changes. And all of a sudden, you drop COVID. Now, we all know what it looked like here in Malaysia, all right? This is probably one of the toughest places. You couldn't even go out at night. You couldn't buy your groceries and stuff like that. It wasn't that bad in Ukraine, but it was a disruptor in terms of the way that they did treatment. So let's take a look at what happened with that. we ended up doing was we did weekly. We changed our sort of approach, and we met with them more frequently. Let me just tell you, the doctors were freaking out. They thought if we gave people take-home dosing, they're all going to take this medication home, they're going to overdose, and they're going to die, and they're going to heaven. They also said, we don't know how to think about who should be on take-home dosing, who's stable and who's not. So some lectures around that. They could use the Basis 24 if they wanted. They could do a number of different things to identify. And they got some coaching around how to do some of that so they could figure it out. They realized that if they were going to give people take-home dosing, boy, there might be some people who might benefit from some conversations. So a check-in. Let me just call you and say, is everything going okay? Are you stressed out? And of course, everybody was stressed out. I was stressed out. And so they changed the way that they did things. And they did it by force majeure. They didn't have much choice because they had to do something. But they needed the coaching because they didn't have the ideas about what to do. And so this coaching, and then they would say, well, I'm doing this, or I'm using video. I mean, now they're talking about video conferencing, which I think is a little too much, but that's, it is what it is. And they said, we know that from these earlier data that if people got an adequate dose of treatment, that their patients were going to do good no matter what. So they focused more on getting them up. They had much more accelerated rates of increasing the dosing initially so that their patients get stabilized quicker so that they could move them on to take-home dosing and sort of meet those needs. And so the question is what do the data show us about that? So one of the things that we published almost immediately, within 6 months of the switch over there, is that they had gone from a take-home dosing rate of 53%, and they moved it to 82%, which meant almost 30% of their people who would not have met the criteria for take-home dosing, which is 6 months of monthly sobriety tests, urine drug testing, which is really rigid. In order to get, to get any take-home dosing, just shifted immediately. 28% of people who were previously not eligible based upon the Ministry of Health guidelines, all of a sudden could be shifted, and the doctors made the decision to do that. Okay, they were supported and they were coached through that so that they could get through that process. What you can see is that the proportion who went to take-home dosing that is moving towards the green, if you will. I try to color code things. Red is bad, green is good, all right? We see a huge shift in the country sort of moving over to take-home dosing at fairly high levels. Now what's interesting is if you sort of think about what this translates to a year. So I'm coming in, and let's just be very conservative. Let's just say it takes 5 minutes to interact with the patient. You gotta draw up the dose, you gotta get it all ready, you gotta package it, you gotta watch the person take it, and then you gotta record it. So let's just be conservative and say it takes 5 minutes per person. Well, what this really translated to is it translated to, over the course of 1 year, over 1 million less in-person visits. What does this mean for clinicians? That is a demand. If you have to see 1 million patients over the course of a year, that's a lot of time. Translate that to 5 minutes per visit, that's 86,000 hours of clinical time. Well, what can you do if all of a sudden you gain 1,000 patient encounters that you don't have to do, and you gain 86,000 extra hours of time that is potentially available? You shift what you do. You talk to them on the phone, you can enroll new patients, you can do a lot of different things when you've got your hands free to do that. And what we did was we took a look at this with that shift, is we just calculated accrued mortality with that. And so what people worried about, and we did surveys, we would talk to the clinicians on a regular basis, and they would say, we're really afraid of doing this because if we give, Sergey, 7 days of take-home dosing, they're going to take it, they're going to be stressed out, they're going to die and go to heaven. They were really worried about that. We needed to reassure them because we were concerned too. I think everybody across the world was concerned about increased, we didn't know the answer. This was really an incredible sort of experiment as a disruptor. And what we found was that there was no increase in mortality. And so everybody, not everybody, but a few people had a story. And it's true, they're going to have some of that. But on a population level, they did no harm. In fact, it's not statistically different, but it went from 5% mortality per year before the pandemic to 4.2%. So because we have this national database and we have regular reporting, we know who's on treatment, we know what their dose is, we know where they are in the country, we know whether they drop out from treatment, whether they re-enroll, we could take a look at folks. So what we did was we looked at patients who were enrolled for the first 6 months in the year before COVID. So going back to March of 2019, and we took 6 months of enrollment, and then we started from the COVID disruption when the Ministry of Health changed its guidelines and made them more liberal. And we took 6 months of time, and then they each had 1 year of observation in order to see what happened. And what you can see is that the first thing that you notice is that the rate of increase in new patients was significantly higher. It was 284 per month relative to the pre-time, which was 236. And so once again, they're able to have a bigger public health benefit because they've got more time on their hands in order to enroll new patients. But the question is what did it do with retention? And you can see that the retention is higher. Now, shifting to take-home dosing was not the only thing, so we wanted to take a look at the multiple factors that might contribute to higher retention. So this is just stratification. The biggest effect was based upon getting patients on to take-home dosing, but we also see that there were other factors. If they got them on an adequate dose of 90 milligrams or more, if they were HIV negative, we know that there's increased consequences, maybe drug-drug interactions with antiretroviral therapy. Places that enrolled patients more efficiently had higher retention levels, and of course the post-COVID period showed that. So the other part of the question was, we didn't just, so retention, the other sort of term you might use is the opposite of that is dropout. But that dropout, was the dropout due to death or not? And what you can see is that overall, you see an increased survival benefit overall for the COVID cohort. And this was not something that we expected. Now, as it turns out, Ukraine did not have a devastating COVID epidemic. So you might have said some of these deaths could be increased as it relates to COVID. We were unable to break apart the reasons for death. Most of the death ends up being probably HIV and overdose as the most common reasons. But once again, we have a higher survival benefit that happens with the transition to take-home dosing. And then some of the other factors that were associated with death, not surprisingly, is if they had HIV, they were more likely. The take-home dosing was only significant in the post-COVID period. But what we did was we stratified this by quartiles, and we said, is there something about the places that enroll at a higher rate? That is, they have learned how to do things better, and they've been able to sort of respond to this disruptor. Are they able to have a survival benefit differently than others? So we divided them into quartiles in terms of their rate of improvement. And as you can see, that only the quartile that had the highest rate of enrollment, that it took on more patients, they had probably had higher level, it actually translates to higher collaboration climate. These were the folks that actually had the only survival benefit, and it was driving all of the survival benefit in this particular group. So once again, really suggesting that the cohesion and the collaboration was driving some of this. So if I could sort of summarize just what all of this means, being able to reduce the clinical demands on patients. They don't have to come in every day, they don't have to go through the streets, they don't have to give up their job, but also reducing the clinical demands on the providers was really important. And the way that that happened was the transformation of sort of more liberal options for take-home dosing. They were able to recruit more patients as they changed the way that they spent their clinical time, and it ended up having higher retention, and it did not actually cause higher rates of death. And so I think one of the things that this did is it challenged, by the way, we did not include any of the buprenorphine patients in this, this is only methadone, is that it really challenges the paradigm that patients really have to be rigidly monitored for long periods of time before you can sort of move them to take-home dosing. And remember, it wasn't the US where you could start out with 1 day and after many months you can get a second day. They got 7 days, 7 to 10 days immediately. And it was only whenever the clinician had decided they were stable, not some time-dependent effect. So we ended up sort of working through the coaching during ward. We thought we had the COVID stuff calmed down, we were a lot more relaxed, and we that things were good, but we actually got some inside information that this war was going to happen, and we were really working, very carefully with the groups of folks to really plan for this. One of the things that you can see is what's happening is that you've got the area in red is where the conflict region was early on. So we have in the north, we have the invasion down to the capital in Kyiv, and then we have the area that's all along the southern border, and the Donbas region that is in the far east that is being sort of with a Russian military presence. We have really what ended up happening very early on is government. So in other words, they had a functioning government. They moved to Lviv even before all of this happened. They shifted to sort of remote working. They all started, kind of working with Zoom, which was one of the things that they had learned during COVID. So they learned from COVID. So that learning process was sustained. And what you can see is that all of the medications for opioid use disorder were manufactured in two places, Odessa and in Kharkiv. And so one of the first things that happened was they had a lot of medication stored, thankfully, all right? And it was stored just outside of Kyiv, where there's a conflict. One of the things that they did very quickly is they had enough medication to have 21 or 23,000 patients on treatment through October. So there was enough medication around. So that was part of the good planning here. And then they moved the storage of the medication from Kyiv all the way over to the Lviv area in order to protect the stores of medications early on in the invasion. And there were a lot of things that happened in terms of some heroic efforts. People driving with their cars through security passes, getting medications to patients. And what you can see is that in the 21 days before the war broke out, you see that the coverage in OAT differed across the country, not surprising, with some regions doing better than others. One of the places that had one of the highest coverage rates was Lugansk. Every single one of those patients came off of opioid agonist therapy if they stayed in that area. But what ended up happening, as many of you might know, is that patients had to move. So they had to set up systems whereby people in the West were able to accept the patients and continue them on to treatment. We had one place that quadrupled the number of patients they had in 6 months. And it was one of our most efficient places. And it was one of the people who came to the US in the first group, and she created a system whereby they took the patients the day that they showed up as part of that. So let's take a look at what happened early on. So in February the 1st, they were at 17,000 or so patients. 1 month later, 8 days after the war, they dropped off about 800 patients, so we have a drop-off. And what they did, and this was the same thing that happened in terms of COVID, there was a dropout like initially as well. What did they do? They jumped right back in the saddle, they reorganized, they did rapid change cycles, they did things to change what they were doing because they already knew how to do that. And you can see that they caught right back up, they jumped in the saddle, and whether they were cowboys or cowgirls, they did it well, all right? And so they had learned that. So these are sustainability issues that we talk about, because they had changed the processes, they had changed the regulations. They were things that were potentially leading to a more sustainable outcome. And this was done through weekly coaching sessions. You can see Lynn in the top of the fourth from the top to the right, Scott over there. I'm there sort of looking like you can see my sort of turkey chin, and a number of other staff who were on. So we were on meetings very regularly with the team. So what were some of the early responses is that there were 20 sites out of over 200 that shut down, lost them completely, most of them happening in the conflict regions. They were given up to 30 days, imagine, 30 days, not 10 days, 30 days of medications that they could take home, but the provider had the discretion of deciding. So over in the conflict areas, there was more take-home dosing that occurred over there. Most of it was in the 10 to 14 day range. Some places decided they were very anxious and they were concerned that their patients were going to go into withdrawal, that they were going to lose them. They did some temporary tapers. We spent a lot of time saying, please don't do that. Let's find a way to shift them. And so we had to reverse some of that. If we had not done that, that would have gone on and continued on. And then one of the things that was one of the unintended consequences is this is a country that, because it had a constrained resource of methadone, there were many, many, many patients that we can't even count who were in the private clinics. So there had been a sort of a secondary thing The problem is that the Ministry of Health decided that they were not going to sort of provide medications for these private clinics. So these patients had to shift, which meant that they had to go through the whole process of starting on medication and getting them up and dosing. It's one of the things that I think could have been done better, but it was a decision that they made at the government level. But what they did do, that is to their credit, is they said, we will take them no matter where they come from. There were differences in the way that some of the places, if places had what they perceived to be a scarce resource, that is not enough medications, they chose not to add new patients. Other ones said, we understand this is stressful. If you need to get on treatment and you want to not have to worry about that, we're going to get you on medication. So they were sort of a different sort of response. They came up with some creative ways to communicate with patients. They did crowdsourcing to say, all right, from 2 to 4, it's going to be safe. The alarms aren't going to go off. Come get treatment. So they actually sort of changed the way that they did things. They put everybody on sort of group chats in order to get them in. They developed some online message boards, and then they created these sort of closed chat groups. Most of it was done on Telegram, which is a little bit safer than some of the other sort of areas. And then some of the other disruptors is that the supply chains changed. There was some heroic action that kept things going here. And really they had to think about how they would prioritize patients. But ultimately they did actually enroll a lot of new patients. Some of it was initially from the private patients. But you can imagine with disruptions, almost all of the work going on the right in the red, those are places that were leaving, and they were mostly going, some of them, about 6 million people went to Europe, but 3 million people were internally displaced. And, if you happen to be on methadone, these sites have got to pick you up and sort of take care of you. So there was a huge amount of sort of change that occurred with that. There was also the middle of the country, which ended up becoming a transit zone where they had to figure out how to do these sort of disruptions with treatment. And then this is the sort of flow that we mapped out in a recent paper looking at what happened as people were moving towards the west, and these other clinics had to pick it up, and some of the responses that happened right at the conflict. And what this did for the first time is, this is the first time, there have been other disruptors like Hurricane Katrina and other sorts of things that caused patients to have to move methadone. This is in the context of war, and so we would think of this in sort of the conflict sort of context where a number of patients had to be moved and transferred, very quickly to other sorts of regions. We ended up sort of working on a number of different articles with regard to how to do things. One of the things that was a learning lesson is that for the first time, these private patients, the government hates these clinics, just hates them. And we had one place where the guy in the government clinic up in Kharkiv, this is right up on the 16 kilometers from the Russian border, the doctor in the system said, it is too unsafe for me to do this, it's too unsafe for my staff. They signed an agreement. The Ministry of Health would say under duress. I think it was a good thing. But they signed an agreement that says that the doctors and the nurses from the governmental clinics could do the treatment, and this guy would store them in his private pharmacy. And so it became a place of collaboration. And one of the things that was interesting is we saw this relationship evolving. In fact, we had just made a visit to Kharkiv in November, like 3 months before this, and we saw this relationship already evolving, and it was perfectly ripe for them to help each other out in a period of conflict. So these are the kinds of things where sort of unusual bed partners might come together with regard to this work. I'm going to sort of skip over this. One of the things that I will say is that there is a huge amount of support for OAT. Remember when we first started, they really thought that I had horns and a tail. These are 3 social workers. This is on National Women's Day, and I was giving a talk at the United Nations, and they created this little thing for me where these 3 women, and they're all 3 on methadone themselves, and they gave me permission to put this up here. But the first line at the bottom says, opioid agonist therapy equals life. The second one said, we remember Crimea, Lugansk, and Donetsk. And I will point out that when that invasion happened in 2014, there were 785 patients who were abruptly stopped the day, and 10% of them died within 6 months. So they knew what could happen if this OAT was discontinued, and they were committed Social workers would drive across town, with sirens in order to make sure that medications. And the last one says, continue life without interruptions, and they were very committed. So there was a constituency that grew up in parallel to these clinicians who were driving this, because the thought leaders were actually supportive of it. They went from 7,000, and I think we're at 26,000 patients, 26,000 patients on OAT. And so I'm happy to take any questions or comments, but it really sort of speaks to the fact that coaching, which you're going to hear a lot about tomorrow, and the Niatex actually was very supportive, and the lessons learned from before were able to be sustained, but they were also able to be used in order to respond to major disruptions. Questions? How many minutes do we have? I know that I can ramble on. I'm not very good at looking at anything. 6 minutes. I cut out all the Niatex slides, and so I thought maybe, that's good. It's a good time for discussion. And I will say that, for those of you who are thinking about what your questions are, is that disruptions are going to happen all the time in whatever field you are. And it's what you do during those disruptions and what sorts of skills and whether there are collaborative teams that will be able to make a difference, that will work through those. I remember, Luke and Jen will remember this, during our own COVID response at the hospital, we had collaborative team after collaborative team, and we would see patients until 10 o'clock at night and get back up on a call at 6:30 the next morning and get on, even how we were going to move patients around the hospital, who we were going to decide who would get admitted. These are all the sorts of things that happen, and it has to happen quickly, because you have sort of a disaster that is really about to fall. And one of the things that happened at Yale New Haven Hospital, our hospital, is that we had the lowest rate of mortality of any hospital in the country, because we figured out when to open up new ICUs, when to move patients, when to cohort patients in certain areas. And it was this rapid cycle. And I have to give credit to our chair of medicine, who really supported and really led. There was a therapeutics team, there was a movement team, there was an education team. We even started out where, as an infectious disease doctor, I was seeing anywhere between 35 and 45 patients a day, and it wasn't sustainable. I never went home. And we ended up training the trainers. So these are the sort of the implementation changes where we got the hospitalists. So these are the kinds of things that you do in disruption, but you have to be ready to do it. And it's work, but boy, an hour worth of meeting once a week, it will make big changes in what you're trying to do. Questions, comments? Yep.
Hi, Prof. Altice. I'm Hazwani from Kuantan, Pahang. Right, first, it's very inspiring story, really great. It's a salute for you and the team for that kind of changes and the disruption with the disruptions in your research anyway. But yeah, you're talking about collaborations, right? So that means it involves a lot of stakeholders, different stakeholders in your research. All right, I don't know if it's a proper question or not, but of all the stakeholders involved in your research, which one do you say is the most important? I don't want you to rank them, but which is the most important network, or would you say policy makers are the ones that allows you to change things, or would you say your I know, and there's a public, there's a research team, there's a medical team, there's a policy team, right? So
well, it's a little bit different than what we did with Niatex. So I would say that our change teams were not exactly right at first. So we changed that so the executive sponsor was the chief narcologist. But remember what happened. So the chief narcologists were changing the structure. Like some of them would say, like one of the requirements is you had to be screened for TB. Well, we had some places that said, great, we'll screen them for TB, but we'll give them a first dose, and you've got 7 days to get it. So, they worked within the guidelines, but what ended up happening is that we didn't actually do change teams with the policymakers and stuff like that. We coached people who then came back. They were cohesive, and they said, as a group, we want these kinds of changes. So we created a framework. they developed their advocacy, and because they felt empowered, they had knowledge, they had information, and they had experience. And so we didn't really set up any of our, I mean, we ended up going to some of those meetings, but that wasn't really, they were the ones who were making the changes. And so, you know, I would say that, you know, they would then start to work with NGOs. Some of the change projects were to go to the syringe services programs to have them bring in patients. All right, so they came up with sort of new ideas around doing that. I think picking the right group to, you know, to be your change leaders is important. And one of the things that Lynn has taught me throughout all of this work is stay away from the boat anchors. I love this term because the people who throw down the anchor are never going to change. Bypass them, go around them. As Sten said, those 2 or 3 nurses who would try to talk patients out, move them, and whatever it is. There are different ways of, you know, sort of doing that. So our intervention was not designed, nor did we actively approach all those things. We provided data. I mean, their change teams did that, but they were the ones who felt empowered. And one of the things that I really sort of learned about, and we're testing it in like in a custodial system, is whether the collaboration that evolves by working with each other is really one of the key factors. We did not study that a priori in this study. We're looking at it prospectively in another study, and you know, but it is really about having the right, you know, person who can actually make a difference not only below but above. And your change teams can actually start small, but they just need some support from the executive sponsor. They don't have to be someone that powerful. Just in Ukraine, it's very hierarchical and it was important. Did I get that right, Lynn? Okay. Stan.
So I am absolutely blown away by this work. It is so extraordinary because it's completely against what one might expect in a time of immense crisis. I just don't see studies showing massively improved coverage and outcomes when one is massively constrained by COVID and civil strife and war. You've been very clear as to why, which is that this was the right policy to do anyway. Bring the drug to the patient in a highly convenient way, minimal disruption of their jobs, their families, their lives, and these outside circumstances forced an innovative internal change that you've been advocating for with your colleagues for a long time. I still am blown away because COVID and war and your findings are so favorable. I mean, that delta was massive. So here's my skeptical scientist question.
Yep.
Is there a possibility that you lost patients from the pool due to the disruption of COVID, isolation, you know, people actually having to move during war, and that you were studying a retained pool of individuals, that there was, I'm just making up this number, 20% of people who were the unseen cohort.
Yeah.
They didn't come into your cohort because you already lost them, and it still doesn't take anything away from your work. But I'm just wondering whether there was a subset of people who were just lost up front.
So probably what I didn't make clear with the COVID assessment, and we haven't analyzed the data in the same way for the war in terms of the detail, but with the COVID assessment, we only took new entrants, people who were newly entering treatment, so we did not have a cohorting effect of the good patients. So we only took people who got their first dose of methadone during that 6 months of each of those periods in order to avoid that bias. So I think that that's a good point, but we made that decision from an analysis perspective in order to really get rid of the good patient, bias, which is true. And we saw it anyway, but when we controlled for this, we actually did better. And part of that is that people were, they were really afraid, they were stressed out, they needed to do something different, they came into treatment, and they might have been more motivated, but they certainly got more patients in during that time period. I think that, with they had lockdowns as well, not quite as severe as here in Malaysia, but, people were constrained. I mean, they really were. They had to have a reason, to go out there. But from an analytical perspective, we tried to protect from that by doing that. And in an earlier version of this paper, we didn't actually limit it to that. We did that on the basis of a reviewer comments. So it might have been said.
Can we take one last question?
Yep.
Table 9.
Is it table 9 or table 6? Kidding.
Thanks. So I'm Suresh. I would like to ask a question. When COVID hit us, or the global as we see it, it was disruption, as all of us know, right? So what we generally would have experienced would be there need to be prioritization in terms of selections. What activity we would like to continue and what activity we would like to modify and whatnot. So when you escalate it into such a big effort like this, war versus COVID, and so do you have pressures in terms of selecting this kind of activities to continue with whatever you have done?
We basically took the position that this is a disruptor. We still have a